Welcome to the Virtual Neurology Summit. My name is Dr. Corey Zimney. I'm an assistant professor at the University of South Dakota. I also, in the physical therapy program, I also am a senior faculty member with International Spine and Pain Institute, where we do lots of teaching in regards to pain neuroscience education. Just a few quick disclaimers before we get into the program. One, I do publish books and receive honorarium for those. Again, it's not the intent to share those, but more to talk about our research. And I do teach, like I said, for International Spine and Pain Institute. Again, it's not intended to promote those seminars either. The objectives is hopefully we can get you to help understand some of the available evidence a little bit more and the basic components behind pain neuroscience education to use in a clinical setting, and also look at outline some of the various other therapies to use in conjunction with pain neuroscience education, what we refer to as pain neuroscience education plus, and then appreciate just the various complexities behind pain and how we can change this neuroendocrine immune systems. So for many of us in healthcare, math may have never been our major strong suit, and that's why we went into the healthcare professions and not engineering. But oftentimes we see pain in this very simplistic format of pain equaling tissue injury. It's been around ever since Rene Descartes talked about the little boy with his foot in the fire. When he put the foot in the fire, that created fluids to flow up into an area up into the brain that caused them to have pain, and it was seen as always a tissue injury type of situation, that pain was either seen as physical with real tissue injury, or it was more psychosomatic, psychological within the mind or made up. And we know now that, again, that's not, that type of math problem doesn't do so well, but many times we still work in this system where pain and tissue injury are seen as the same thing, and the more pain you have, obviously the more tissue injury you must have, and all we need to do is intervene and the pain should disappear. But we start to understand it becomes a little bit more complex over time. We have many patients that want to enter our doorways and into our clinics, and we see they'll have significant amounts of pain, 9, 10, 12, 15 out of 20 type pain out of 10. And very little pathology that we can find on scanning or anything along those sorts. And we saw that start to increase with the rise with disability, things such as railway back in the mid-1800s, where people were coming in complaining of the significant back when they started getting compensation. And we started to understand some more of these psychological factors and social factors that started to play into it. We also understand it's complex because it goes the other direction. Some people have significant pathology and have little to no pain, which creates some more complexity to it. As, for example, this young gentleman went into the doctor because of some headaches, and he did some scanning and some testing, and they found he had this large nail embedded into his head. The individual remembered it most likely happened 4 years earlier when a nail gun he had been working with, he thought had misfired, but eventually obviously did fire, and it lodged a nail inside of his head. And these things have been recorded for a long period of time. Harry Beecher's work back during World War II, when many of the soldiers would come off the battlefield, off the front lines with all sorts of significant injuries and record little to no pain, and they wouldn't be asking for morphine and all the other pain medication drugs that were available at the time. So significant pathology was found, but little to no symptoms. So we understand pain is much more complex than just being pain equaling tissue injury. If we use the International Association's study of pain definition, where pain is this unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And this definition, as I've highlighted and underline a few key things that are very key for us to understand. One is pain is this: it's both sensory and emotional. Different from Descartes, where it was thought to be physical, sensory, or emotional, made up of the mind, that it was one or the other. We recognize now pain is always both. It's both always sensory and emotional. It always has both components, and we just understand the neurology, both the medial and lateral pain pathways. As the nociceptive information enters into the brain, we understand that it's always going to have both these sensory and emotional components to it. It also has actual or potential tissue damage. Tissue injury in and of itself does not necessarily always have to lead to pain. It can just be the potential threat of tissue damage that can lead to a pain experience as well. And the last is just that experience. Pain is an experience. It's not a thing. It's not a tissue. It's not something we can physically grab or get a hold of. It's this overall experiential, and that's why it's unique and individual to every person, because everybody experiences things slightly different based off of their own unique individuality. Here in the U.S. and across the world, pain is a big problem. The Institute of Medicine's Relieving Pain in America report back in 2011 talked to us and told us that there was over 100 million Americans having some form of persistent chronic pain that they were dealing with on a regular basis. Just to give us a little perspective of that, if we take everybody here in the U.S. that has diabetes, heart disease, and cancer, and we put all those people together, that group in and of itself is still not as large as all the people suffering from persistent pain. Now, in the midst of our opioid epidemic, we recognize again the secondary problem that's going on with this significant persistent pain. Where pain previously was thought, well, it can't quote unquote kill you, where heart disease and cancer and diabetes like that can, we're now recognizing again pain because of the secondary problems with opioids can lead to unfortunate deaths for individuals. The other problem that we have to look and recognize from a societal standpoint, how we treat and how we relate to these individuals is often different. You think of an individual that's sitting at home who maybe just had a heart issue, who maybe underwent open heart surgery, call up their friends to ask them for some assistance with housework, taking care of the yard. Many people will come over to assist that person. The person going through cancer treatment, going through a series of radiation and chemotherapy, who may be unable to take care of things around the house and calling for assistance, and many people will come over to assist that individual. Now contrast that with that person that's suffering from chronic and persistent pain. Maybe they've had years of fibromyalgia or failed low back surgeries. Again, how our culture and society views that person is much different. Because with that person who underwent heart surgery, it's easy to see the scars on their chest. The person going through cancer treatments, we recognize, again, the chemo, radiation, what that can do to them. But that person with persistent pain, it's much more difficult to, quote-unquote, see any damage externally. There's not that thing that we can grab a hold of, and unfortunately, oftentimes our society maybe treats that person slightly different. So really, Louis Gifford, I think, provided us with this nice mature organism model to really start to understand the many complexities behind pain. And through the research and through what we've found over the last 15, 20 years as we start to slowly unravel to understand pain just a little bit further, this mature organism model does a nice job of breaking it down into the various components such as tissue inputs, environmental inputs, just the peripheral nervous system input itself, the central nervous processing that happens at the spinal cord level all the way up into the brain, and the various output mechanisms from the neuroendocrine and immune responses that it can occur when a person has a pain experience. So if we take a look at each of these just individually just a little bit to understand pain and the complexities and the modulation that occurs, we can look at input mechanisms. We can look at just the tissues themselves. Tissues do create nociceptive information and they can provide input into the system, and we do need to do a good job in therapy and in medicine to help really evaluate these to see if these may be some kind of area that can be treated. We also have to understand the environmental issues. They can have both positive and negative influences. So again, culture and family, where the injury that happened. We know now that individuals that are in what we call an adrenal sensitive, a higher stress type environment, are 6, 7, 8 times more likely to develop chronic and persistent pain, because it can change just based off of the environmental issues that are occurring in and around maybe when an injury occurred. We also have to look at just what we call the peripheral neurogenic, the peripheral nervous system, and the various processes that go on with that. We know now that ion channel expression is constantly changing, changes to blood flow and immune responses and how the peripheral nervous system uses that, and that can modulate and change the nociceptive information being passed through that, and that can alter and change the pain expression that a person may have due to these input mechanisms. And then when we move into the central nervous system, just as a spinal cord alone, and we start to get into things that we start referring to now as the central sensitization, when the central nervous system is involved. And we recognize the change that occurs at the dorsal horn with the beginning work that Melzack and Wall showed us, and then onward with Clifford Woofs and many other people that have looked at the significant changes that happen at the spinal cord level, and the changing with the activation of second order neurons. We can get changing in the receptor fields and the synapsing. All these things that can lead to allodynia and hyperalgesia due to the changes within the spinal cord. As we move on up into the brain, is further research and understanding of the brain over the last 20 years, we started to see how things such as perception and consciousness and understanding memory in the various different areas of the brain can be altered and shifted with these individuals. And these shifts don't happen only just from a functional standpoint, but also a structural standpoint. We know, unfortunately, people that suffer with persistent pain oftentimes have a change in their gray matter, and the processing and the functionality of those different areas within the amygdala, anterior cingulate, start to alter and shift again the longer the pain persists with individuals. And then we start to understand that much of this is altered through these psychosocial factors, oftentimes referred to the yellow flags, that many of these previous experiences and their beliefs and thoughts can alter and shift how the brain processes the information. And then the last is the various output mechanisms that we're starting to appreciate more and more. That when we're in this chronic stress state, which again, chronic and persistent pain is seen as a chronic stress state, how the HPA axis and the activation of the adrenal glands and cortisol and the changes within the immune system with the cytokines, how that can affect both the brain and the tissues, and that the brain will start to change and alter with this change in cortisol and cytokine immune activity, and also the tissues become more sensitive when we get this increase in upregulation and change in cortisol and immune system activity. And that's where, like I said, it becomes this neuroendocrine immune response that we're just starting to understand further and further. So really we try to see pain not as a simple math that pain always means tissue injury, but pain really emerges from a person. And I like to say the whole person. It's not just their brain, it's not just their body, it's not just the environment, it's all of that. It's the person in an environment, both their brain and their body, all of that. So pain is really this multiple system output that's activated anytime that individual pain specific neural signature is activated. So those various different areas of the brain, which is again activated through the body system itself and based off of the environmental information, when that neural signature gets activated, it can produce pain. And it produces pain anytime the brain and the person starts to perceive a threat. So anytime there's a threat involved, it's going to go into a protective mode, which is it's going to use pain as its protective mechanism. Just like when you're hungry, your body's going to produce hunger to get you to activate, to do some kind of output to get over that hunger. Pain is the same thing. It's going to produce you into that protective response because your body is potentially under threat. And when we start to understand threat a little bit more broadly, we recognize it's not just injury. While injury can be one of those components, a lot of different things within the whole context can start to alter and change threats. So what they think about the surgery or the accident, the disease, maybe the words that were used with the disease. Maybe they were told they had some degenerative disc disease, and the patient may hear that and thinking, geez, it must be that my disc is disintegrating away and I maybe will no longer have a disc. Or if I'm told I have arthritis, and patients' perceptions of arthritis sometimes are very negative. And if you read again, a lot of the research in the literature in patients' perceptions, things such as arthritis, oftentimes they'll see themselves as potentially being debilitated within just a few years. And we start to recognize fear and catastrophization regarding this in the social areas. All of these different things can all be significant threats that can alter and change a person's individual pain experience. So what do we know about treating people with persistent pain? Well, there's a lot of different ways to do it. All you have to do is stay up late at night, watch lots of infomercials, watch all sorts of commercials. Everybody seems to have the magic pill, how to get rid of your back pain, how to treat this and how to treat that, all sorts of braces, injections, surgeries, therapies, many things are out there. And I think Anton Chekhov's quote fits very well when we start to talk about treating persistent pain, that when there's lots of remedies suggested, that again it may not necessarily be able to be cured. That pain is very much more complex than just any single one type of treatment intervention, and we need to move past this magical bullet thought that any one treatment is going to fix somebody's pain again on a wide scale basis. It just doesn't exist. Pain is way too complex when we understand the biology, the physiology, the neurology behind it, that again it's going to take a more broad spectrum approach. So here's some things that we know about pain is that cognitions and beliefs, again, are highly intertwined with a clinical pain presentation. What a person thinks and believes has a large percent to do with how they're going to have their clinical pain presentation presented. Fear avoidance, pain catastrophization are two very significant constructs that have been studied that we know significantly impact an overall pain experience. And one way to normalize a pain experience can be associated with their misbeliefs is through a pain education and patient education. So when we look at patient education, many current education models, again, have their limitations. They don't really explain the complexities associated with pain. Oftentimes they look at just pain and tissue injury being the same thing, this pure pathophysiological approach. They don't embrace this more interdisciplinary, more biopsychosocial approach. They don't look at the many other threats that potentially could be involved in a person's pain experience. Many traditional pain education formats, again, actually had very limited, if not all, pain and function improvement. If anything, they may have actually worsened it because they may be added to fear and anxiety because of the words, the images that they used, may have actually increased the potentially more injury and having more pain sensitivity with this that these people may experience. So really we've started to evolve and try to grow this what we call now more pain neuroscience educational approach, really where we try to reconceptualize the pain experience to become less threatening to the individual. If we can get them to recognize that pain and injury are two separate things are very, very important. That while they can have pain, it doesn't necessarily mean that they have injury going on. And when we can do a good sound evaluation on them and to help them understand that they have no significant injury going on, that it's more of a pain problem going on, that how we treat that is entirely different than if it's an injury type problem. And if we can make that less threatening, we can reduce that pain experience and we can get them back functioning and doing more and more. So what do we know about pain neuroscience education? Patients are definitely interested in it, especially when they've suffered with chronic pain for a long period of time. They want to know more about it. Other things that they want to know, they don't necessarily need to know the anatomy and biomechanics. Oftentimes they're interested just in the pain and how pain actually works. We know that our overall understanding of pain neuroscience has increased considerably over the last 20 years with our research and our ability to understand the human body greater and greater. And patients can learn this information. We've done multiple trials where we've taught this information to patients, and we use metaphors and examples and pictures and stories. We can put it in language that's understandable to them. And again, our current pain neuroscience should use these. So when we use these stories and metaphors and examples, we can get this information transferred to patients. So how do we know if it works? Well, that's one of the things that we did. Our group, we did a systematic review of literature. We looked at the 13 different RCTs that were out there, and what we found is that, again, when we truly teach and get patients to understand pain from this neurobiological, physiological perspective, and they truly understand it, they actually experience less pain. They have less pain. They function and they move better. They have less fear, catastrophization. They start to exercise. They do more, and they spend less money on healthcare. They become more self-efficacious. They're able to take care of things on their own. And when we look at the numbers needed to treat for this, we recognize pain science education stacks up very well compared to other treatment interventions that are out there. So for function, to improve function, we recognize the number needed to treat is 1 out of every 2, decreasing pain for 1 out of every 3 patients. So again, recognize again, this is not a cure-all, fix-all for everybody, and that's where we'll get into the pain neuroscience education plus the other treatments that need to be involved. But we can see that pain science education definitely has a place to help patients with pain. So how do we go about doing this? Oftentimes it's done through these stories and metaphors. We'll talk to somebody about their wonderful human body and getting to understand they have this wonderful nervous system that spreads 45 miles worth of nerves all throughout their entire body. Those nerves are just waiting there to be activated. So for example, if you stepped on a nail, that nervous system is going to wake up, that alarm's going to be activated, and it's going to send a message. The message is going to be received by your brain saying, most likely to have you take action, take the nail out, go get a tetanus shot, maybe remember to wear shoes. around rusted nails, it's going to create action. And typically, oftentimes we would expect that that alarm system then would quiet back down, waiting for the next time to be activated. But we know now through the evidence and through the research of what we found is that about 1 in 4 times it will stay a little bit more sensitive. Again, lots of different reasons why it could stay more sensitive, but we do know the nervous system can stay a little bit more sensitive with many individuals. And now we're starting to get patients to understand, again, that their alarm system, their nervous system can be more sensitive, and it doesn't necessarily mean that they have to have more injury going on. And we oftentimes will use an alarm system analogy. So just like your house alarm, if you have a super alarm system, something as simple as just a leaf blowing by your house could activate your alarm system, while your alarm system is meant to protect from intruders, dangerous people entering into your house. It may be activated by something simple as a leaf being blown by and touching your house. And it's just become too sensitive an alarm system. And this is what we try to get patients to understand on how their nervous system, how their alarm system works. We try to separate pain and injury. We might use a simple story or metaphor about a sprained ankle, that if you're walking across the street and sprain your ankle, but you see a bus coming at you, would your ankle hurt? And most people quickly recognize probably not. They'd probably sprint across the street, and if they got across the street, then their ankle might hurt. And it gets them to recognize that at the moment of the tissue injury, they may not experience pain because the impending threat of a speeding bus coming at them might be more threatening, and that then the body uses wonderful endogenous opioids to again decrease that pain experience, so that again you can activate to get yourself away from injury. Again, another way to get people to understand pain and injury are these separate things, is many patients have experienced times where maybe they've had a bruise or a cut and they experience no pain. So they start to understand that in those situations they could have tissue injury, but maybe no pain on the opposite side. Or the vice versa could happen. For example, somebody with phantom limb pain, like this little boy playing soccer with an arm. His arm may be painful to him, and many patients have heard of things such as phantom limb pain, and to understand that it's very real pain to have pain in an arm that's no longer there, because again the areas in the brain are still there, what we term the homunculus in our medical terms. This area of the brain, when it's activated, still can create pain into that area that it represents in regards to the arm. So in this situation, this little boy may have pain in his arm, but there's no tissue to actually get injured. So we can have these two varying levels where we can have pain with no injury, such as in this case, or the former case where we might get a bruise somewhere where we have no pain, but we have obvious tissue injury. And we start to get them to try to unravel, to take apart that long-held belief that pain and tissue injury are always the same thing. And when we can alter and shift that thought, it can be a step towards starting to get back to more function and doing more things. And it's through these educational stories and metaphors that are very key for us to unravel and to get them to recognize how the pain system works. Again, it's more of a sensitivity of the nervous system, and oftentimes less to do with trauma or damage to the tissues. And so we get them to recognize there can be tissue problems, but in many situations there's also pain problems where, again, it's more of a sensitivity of the nervous system. And when we can alter and shift those beliefs, we can then progress them with what we refer to oftentimes as the P&E Plus program. And that's very much needed, because one thing that we found when we did our systematic review, when we looked at the 13 different studies, 5 of them did just pain neuroscience education only, as done as a part of science. In each of those 5 studies, none of them found any reductions in pain. But when we looked at the other studies, what we found was that all but one of these studies had a statistically significant decrease in their pain ratings. When we added things such as movement and change of behavior, activity, when we added into this, we really start to alter and shift in what we refer to as P&E+. Bill Fordyce said it well. Education to behavior change is like throwing wet spaghetti at a brick. It's just not going to stick. So you can provide all the education you want. It's not going to change their behavior. It's not going to improve their function. And really that's what we have to do with our individuals with pain, is to help them get back functioning more and more. So again, we use the education as a tool to allow them then to move into the P&E Plus type program, to where we can start to get them to do more activities. And when we say P&E Plus, it can be all sorts of things. These are all the different areas of things, and again, things that have been researched and show evidence behind that can help reduce a pain experience. And again, recognizing that each individual is highly unique and individual. Again, it's an experience for that person. So we have to look for what type of things may work best with that individual. Many different things that we can do, such as breathing and diet, yoga, different manual therapies, relaxation, meditation, coping skills. All of these different interventions have been shown at different times to be helpful for individuals. Within these, we often refer to our 4 pillars, the 4 things that we feel oftentimes through the evidence, through the research has shown us that these 4 things need to be present with all of our programs. Is we need to have that pain science education. They need to understand why they hurt. Again, that is not necessarily always damage to the tissues, but oftentimes it has more to do with the sensitivity of the nervous system. The importance of aerobic exercises can't be denied. Gold level evidence from Cochrane reviews demonstrating that aerobic exercise is utmost important to individuals in pain. How we pace that, how we grade that is very important. But in that process, when they understand that when they hurt doing that, that hurt is not causing further harm to their body, and that's why that pain science education is so important. Because to get them to do the aerobic exercises, they have to have that understanding that the pain that they're experiencing is not causing them any further damage to their body. Sleep and sleep hygiene is key and vital. More and more research is pointing to the importance of sleep for brain health, and we are starting to understand, and we have to appreciate that many chronic and persistent pain problems have a significant brain component to them, that many of the areas of the brains aren't functioning both structurally and functioning quite as well, and sleep is a key component to restore brain health. And the other is the motivational goal setting. We have to set up realistic motivational goals to get these people to persist through these type of situations that they're dealing with, and creating a positive goal setting through graded exposure and pacing programs to get them back to functioning. And again, not just goals on reduction of pain, but goals of function, getting back to doing what it is that they want to do and tapping in to those positive systems within the body. And recognizing that it takes all of them. Too often we see patients that will go through, and we use this analogy with them, such as a car with flat tires, is to get the car to work well, we have to get all the tires inflated. So oftentimes we'll hear patients saying, well, I did meditation and it didn't work for me. Oh, I tried to work on my sleep, but it didn't fix my pain. Oh, I used to exercise, but it didn't work. And the problem is in situations like that, they're filling up one tire at a time and expecting a car to be able to go. What we recognize is we have to get all the tires filled up, and then and only then will the car be able to progress and move forward like it's supposed to. So anytime we have a lack in one of the areas, it may lead to why the program isn't working. We have to get that overall person well again. So we have to get them to understand things through education. We have to have them motivated through their goals. We have to help them sleep better, exercise, move more, relax and meditate. All of those various components, we have to get all those systems working well to help that individual progress and do well. That no one of them probably is going to be an individual magic bullet, that it's a combination of all these multidisciplinary, series is to help the overall person become well again, what we refer to as the P&E Plus program. So just a closing thought for a day in the life, as I talked about Louis Gifford before, with some of his mature organism model that he helped shared with us, offered us many insights to helping individuals suffering from chronic and persistent pain. He was often said that at his clinic, not everybody was fixed, but everybody was heard and cared for. Everybody was given the time they needed and the starting tools to help them recover and rehabilitate. And I think this is key when we start to look. Oftentimes there's many things that we don't need to fix or maybe can't be fixed in individuals, but we can always hear and we can always care for them. And these psychosocial factors of creating a therapeutic alliance, providing trust with that individual that you are there to guide and to help them, can be very instrumental to help them move forward and increase in their function. We can give them the tools. Again, it's not our job as healthcare providers to fix them. It's our job to help get them the tools that they need to be able to move forward, that they can recover, they can rehabilitate, because the body has an amazing potential for adaptability to recover and to rehabilitate in many situations and to be able to overcome. And we have to be able to tap into those things and create the starting tools to help a person get into that, to be able to help them get back to doing the functional activities that they once did and want to do again. And that is really the key behind what it is that we're trying to do with a pain neuroscience educational program wrapped around all the P&E Plus programs that we can do to assist individuals. Thank you for this wonderful opportunity to talk to you here at the Pain Neurology Summit and just sharing with you a few insights in regards to pain neuroscience education and the Pain Neuroscience Education Plus program. Again, if you need to reach me for further information, feel free to contact me at corey.zimney@usd.edu. I'd be glad to get back to you in regards to any information regarding that. And again, we're constantly continuing to research. So again, if you're in a clinic area and want to be involved in research, get in touch with us as well. We're happy to bring along clinical partners so that we continue to do research in the areas of pain science education through both the Therapeutic Neuroscience Research Group with International Spine and Pain Institute, and also with my Center for Brain and Behavioral Research as a part of my work with the University of South Dakota. Again, thank you for this opportunity, and hope you have a wonderful rest of the conference.